Okay, thanks, Eddie. I think it's a very nice summary of what you have achieved in Germany. And I think a lot of people are very impressed what you have done there. I wanted just to briefly introduce what we are doing in Australia at the moment. And most of you know Acute Pain Management Scientific Evidence. Our chair lady had already kindly acknowledged this document. Most of you are familiar with this. This was the second edition in 2005. And there was a working party involved, which was then doing the same later. You see in 2005, this was approved by the NHMRC, the National Health and Medical Research Council of Australia, and then endorsed by a number of mainly Australian organizations in that time, but also you see the International Association for the Study of Pain endorsed it as the scientific evidence document for acute pain, and the Royal College of Anaesthetists is actually a member on the working party in the UK, and it became also their document. We have a system that requires that we update that every 5 years, and so in 2010 the next edition appeared, and again endorsed by the Australian government through the NHMRC, but now you see there were already a lot more international organizations, in particular in the Asian area, like Malaysia with Ramani Vijayam, for example, in Singapore and Hong Kong, who were involved. But you see also the American Academy of Pain Medicine recommended this document, and the ISP did it too, but they were a little bit late, so we couldn't print them into it because the printer had already started printing when we got their final approval. If you want it, it's on the web for free. Printed copies are sold out, we have no more left. If you go on the Australian New Zealand College of Anaesthetists website under resources and books and publications, you can easily find it, but also if you type in the title, you get a PDF with the whole document for free. It's 530 pages only as a warning. My head of department where I spent my sabbatical when we published this told the secretary to print it for me, and then he told me I should have warned him because his printer went through 530 pages of color prints. So don't print it if you want to save your printer's cartridges, but it's actually very useful on the PDF. We are working at the moment on the 4th edition, and I'm now the unlucky chair of the working party because Pam McIntyre, after 2 times doing it, said I can't do that a 3rd time, and after doing it 1 time I don't understand how she did it the 2nd time, because it is really, I'm now in the 4th month of 6 months of sabbatical trying to finish that, and it is really impossible. We have a cutoff point for literature review in August 2014, exactly 5 years after the last cutoff point. It will be hopefully launched if I make it and don't get a nervous breakdown on the way. It's ANZCA ASM in Adelaide in May 2015, and other than David Scott, regrettably nobody from the old working party is still on board because they were all too exhausted, but it is an interesting exercise. We didn't expect that so much changed in 5 years, although the history should have told us. We are collecting preferred evidence, highest rank, highest quality, Cochrane database as a source of high quality material, and we then, those of you who have looked into the document, see that the main messages are so-called key messages, and if you only want to read really the essence, it's enough to read the first 50 pages or so, which is the key messages. Then comes all the explanation and all the references. We follow the NHMRC levels of evidence system with levels 1 to 4, and after long discussion with the NHMRC, we were actually permitted to add what we call our tick boxes, and this is recommended best practice based on clinical experience and expert opinion, because there are certain things, and you all know that, which are actually impossible to test ever in a randomized controlled trial. You know that one thing what was never tested in a randomized controlled trial were parachutes, but still everybody is wearing them. And there are similar things in medicine which you will never test in a randomized controlled trial. This was a really hard battle because the NHMRC that these are our levels of evidence, that's it. And we felt we couldn't do a proper document without that, and we finally won that battle. This is how a key message part looks, only to give you a little idea, N means this is a new statement which wasn't there the last time. Level 1 would be RCT if it is a meta-analysis. If it is, for example, a Cochrane review, this would be labeled as an additional quality. Level 2 would be a randomized controlled trial. W stands for weakened, S stands for strengthened. We have a system of rating what is happening, and you see here a tick box which is trying to summarize what can't be evidence. As I mentioned, we should have been forewarned that the task will be bigger and bigger and bigger, because if you follow the 3 editions, 1, 2, 3, then you see we went from 34 key messages overall in 1999 to 108 level 1 messages in 2005, and in 2010, 190 level 1 evidence-based messages. And you can imagine that this is continuing. So when I started the project, we had an EndNote library with 3,900 references. We are not finished, and we are now at 5,900 references. So you can imagine what has happened in 5 years' time. So it is a major undertaking. I want to briefly highlight 3 areas where personalized care comes into such guidelines: pain assessment, pharmacogenomics, and procedure-specific issues, which Eddie already alluded a little bit to. With regard to pain assessment, you see here the messages which will be in the new guidelines, and you see, for example, the pain measurement tool chosen should be appropriate to the individual patient. Developmental, cognitive, emotional, language, and cultural factors should be considered, which clearly means there is not one tool for everybody. The pain measurement tool should be appropriate to the clinical context, e.g. intensive care, ward, community, and so on and so forth. So in pain assessment, there is no question that we will need personalized care as one example where these guidelines cannot be universal. Another example would be pharmacogenomics. And you see here, for example, cytochrome P452D6 polymorphisms affect plasma concentrations of active metabolites of codeine, oxycodone, and tramadol, and may cause toxicity in ultra-rapid metabolizers. And again, that would mean that you need to individualize the approach, or for us in particular, in Perth with a very high Asian population, an important issue, the A11AG polymorphism of the opioid receptor affects opioid requirements in acute pain, and that can be up to 40% more opioid requirements than other people, and that is in particular relevant in Asian populations where around 30 to 40% of patients have mutations which are affected by them. So that would be another example of personalized care. And then we will have in the new guidelines even more of an emphasis on procedure-specific management and outcome strategies, and this is just a publication which appeared a few weeks ago in Best Practice, in which we have tried to summarize the data on procedure-specific, which are based on, as Eddie mentioned, the now 12 years we are working together in Prospect. And the reason is pretty much that even though you can say a certain drug or a certain technique works or doesn't work and has an NNT of such and such, it still means that if you are looking at different operations, you will have different types of pain: visceral pain, bone pain, neuropathic pain. You will have different pain intensities, and we heard already from the data from Gerreshagen that actually some operations are totally underestimated in their pain intensity. That might actually be in particular because they haven't drawn the attention of acute pain services and are more or less flying under the radar of acute pain services, and maybe we need to change our approach here. We have different locations of pain, which will clearly influence, for example, selection of regional techniques, paravertebral catheter, thoracic epidural, and so on. And clearly that means that if you look at a given operation, there is a different risk-benefit ratio for this operation than for another operation. And that means that, yes, it is important to have evidence-based statements, but it is at least as important to look at procedure-specific issues. And some of you know Prospect already. If not, there is a website. It is again for free. It doesn't exist as a book. because if you look at it, there's so many layers that we cannot print it. We tried initially proofreading in printed versions and it failed completely. So we now have a test website where we can proofread, which is not publicly accessible, and then it is switched to public access when we have proofread it. What we try to provide is up-to-date evidence-based and procedure-specific guidelines and make these two practice recommendations which hopefully encourage best practice. And an example is this one here for total hip arthroplasty, where you see already again individualized care. For example, for high-risk patients, there is a separate pathway, and then there are pathways if your hospital can't use one of the techniques for infrastructure reasons and so on and so forth. And as Eddie mentioned, we have already now a considerable number of operations online. And we have, as you can see, deliberately selected operations which are A, very common, and B, very different. So we have two very common orthopedic operations, total hip and total knee. We have thoracotomy because of the major pain involved in it. We have minor operations like hernia repair. We have a laparoscopic operation. We have non-cosmetic breast surgery because of the high risk of neuropathic pain subsequently. And at the moment, we are hopefully weeks away or months from actually going live with C-section as the latest operation we've done. So I think that illustrates a little bit that you need individualized guidelines, and even if individualizing means addressing a specific operation. So in conclusion, I think summarizing the scientific evidence on acute pain management in one document is a recognized proposal, and we think that we should continue with this, and we will hopefully find somebody crazy enough to chair this group every 5 years. I don't know if I will do it another time, but the last time I couldn't say no because otherwise the document would have died. So doing it in 5-year intervals seems to be the right time frame. And although we provide very general evidence-based statements, that doesn't mean that we don't recognize that there is a need for individualized care. And hopefully with the 3 examples, assessment of pain, genomics, and procedure-specific, I've illustrated a little bit that there are many faces in the crowd. And yes, the overall document is for the crowd, but we will need individualized approaches. Thank you very much for your attention.